Dear friends, dear colleagues, dobre večer. I don't know if it's the appropriate time of the day to say this, but it's the only word I've learned in Bulgarian language. But anyhow, I'd really like to thank Dr. Kraseva for the very kind invitation to participate in this fascinating event, and of course, Pierre Fabre for hosting this great symposium. I believe that I'm in the most difficult position between me and Dr. Liontos because BRAF targeting that we're going to discuss for colorectal cancer, the challenges and the benefits that may exist from the current treatment is common, but for the reason that I'm going to explain you, it's a little bit more difficult to handle this kind of disease in colorectal cancer, despite novel treatments are available, and I think that the future is going to be even more fascinating. Okay, thank you. And as in all neoplasms, we know that there is a great heterogeneity. The same exists, of course, in colorectal carcinoma. When I started doing my residency, we used to give chemotherapy only to all the patients. But we currently know that half of these have specific mutations in RAS genes, but there are also a specific and important percentage of patients that have mutations in BRAF. And most importantly, the V600E mutation, around 10% of the patients that will be diagnosed with colorectal cancer will have this type of mutation. Of course, there are also other BRAF mutations, and we should not forget this. We do not care only for the existence of a mutation in the gene, but for the specific mutation. Almost 20% of the BRAF mutant colorectal cancer patients will bear non-V600E mutation. So we should be aware of this. And knowing that there is a mutation, does it matter for how we're going to treat the patient, or does it matter for the neoplasm itself? And yes, it does matter, because we know that the BRAF is a part of the MAP kinase pathway, that signaling for proliferation and survival, cell growth. And when we have this specific mutation, the V600E, the BRAF kinase is so potent that induces very rapid proliferation of cancer cell, and the viability and the cell growth is so strong that it is difficult to handle this kind of patients with the available up to now treatments. So not only we know that there is a mutation, but we know that this mutation has a specific biological role. So it is the main pathogenic event for these 10% of patients. This doesn't matter so much for the non-V600 patients, because we know that these non-V600 patients, the kinase is not constitutively activated all the times from the mutations that may have. And you see in this slide that in the top there is a receptor, and it's not by chance that EGFR is in this slide, because we know that EGFR is overexpressed in almost 80% of colorectal carcinomas. And what does it mean? It means that, of course, when you have a mutation in KRAS and RAS in BRAF, the signaling is mediated mostly from the mutated kinase, but when you don't have this mutation, it is the overexpression of EGFR that mediates the proliferative activity and the survival activity in the cancer cells. And I will explain how it is important in colorectal carcinoma. Excuse me. But BRAF V600 mutant cases are not just a mutation that we may have some drugs to give to our patients. And I'm always saying to my colleagues in Greece that we should know the mutations, the molecular biology, we should know the drugs, but we should know the disease itself. And this type of disease is very different from all other advanced metastatic colorectal carcinomas. And why so? Because we know that BRAF V600 mutant patients have higher TNM, stage carcinomas, have an increased percentage of de novo metastatic patients. They have a high probability to have peritoneal disease that we know it is more difficult to handle when we have metastasis. And of course, these patients have a much worse prognosis. And these are data from several studies that show that despite we know that mediocre metastatic colorectal cancer patients have about 3 years of overall survival, specifically the BRAF mutant patients have almost 1 year of it, despite there are also real-world data that's saying that perhaps it's a little bit more, but of course, this mutation characterized adverse prognosis. This is not the case for non-V600, excuse me, non-V600E cases. These non-V600E cases have different characteristics. You know that BRAF V600E mutant patients are more in the right side of the colon, are more frequently MSI high, do not have usually other RAS mutations. The opposite exists, it's the issue for the non-V600 mutant patients, so these patients, as shown by the curves, have better survival. But we should also focus that the V600E mutant patients have a very rapid decline of their clinical status, and they die very soon after diagnosis. So we should be aware that we should monitor these patients very closely so as to provide rapid treatment when it is necessary for these patients. And another thing, we usually try to have metastasectomy in patients that have colorectal metastasis in the liver, and sometimes this is beneficial for the survival of the patients and may also rescue some of these patients. But this is not also the case for the BRAF mutant patients. You see that most of them will recur after the attempt to excise all metastatic disease in the liver. And when we see the survival after metastasectomy, these patients recur very early and do not have such a good prognosis, in contrast to the non-mutant patients. Of course, in the guidelines, there is no exact guidance to avoid metastasectomy in BRAF mutant patients, but we should consider this data when we take clinical decision on how to proceed with a BRAF mutant metastatic colorectal cancer patient. So I believe that we are all convinced that we need to test our patients with at least metastatic disease for specific biomarkers in order, first of all, to know their prognosis. You see how different is the prognosis when you have a BRAF mutation, and also to guide and take therapeutic decision. For example, you know that you have RAS mutations, you cannot use EGFR therapies, and when you have microsatellite instability, these patients have much better responses when immunotherapy is given. It is the preferable treatment, at least at this time, for these patients. So these three biomarkers should be tested at every patient that is diagnosed with metastatic colorectal cancer. And we should know that BRAF V600E mutation, the presence of this mutation, is an adverse prognostic feature, and also, as we'll see, is a biomarker that may guide our treatment now and even better in the near future. What are the data for these patients that were up to now treated with chemotherapy plus minus anti-VEGF therapy in the first-line treatment is that they have a very bad prognosis. They have PFS for less than 6 months, and even more, almost half of these patients, we don't have the ability to receive a second-line treatment. So we eagerly need new therapeutic options for this population of patients. And you all know the results from the Beacon trial that was designed on the basis of the clinical history of these patients. In the Beacon trial, patients that had received at least one prior regimen for their metastatic disease and were not exposed to EGFR or MEK inhibition or RAF inhibition were split to receive either the combination of encorafenib and cetuximab, or the triple combination with encorafenib, binimetinib, and cetuximab versus the standard of care with chemotherapy plus cetuximab. And you know very well that according to this study, there was a significant prolongation in the overall survival when the patients received encorafenib and cetuximab in comparison to the standard of care. And it was not just a prolongation of survival, we also had responses to these patients that are usually unresponsive to all other available treatment options. And this is very significant, not just to live longer, but also to have a better quality of life. And it is significant to have a treatment that could ameliorate the symptoms that these patients very frequently have. Of course, as we said, this was it was a clinical trial among standard of care, double therapy, and triplet therapy, and you see from the survival data that there was not significant difference, at least from the curves, between the double and triplet therapy. Although perhaps there are subgroups of patients that may are of benefit with the triplet therapy, despite, of course, we have more adverse events. And this difference in overall survival was due to the difference provided by the encorafenib-cetuximab combination in the time until the progression of the disease. And you see that with this combination, we don't have this sharp decrease in PFS that we see with other standard of care, the available chemotherapy treatment that is very important for a population of patients that have such an adverse prognosis. Of course, the results also here didn't differ significantly between the double and the triplet therapy, as we all very well know. And for all of us that we have used this combination in clinical practice, we know that there are adverse events, but this is a quite safe treatment, and we can now handle very easily the adverse events that may occur with the patients. Of course, a proportion of them through the clinical trials even are due to the significant burden of the disease and the clinical deterioration that have the patients due to the disease itself. And we see from the quality of life questionnaires that the combination with encorafenib, cetuximab, and even more the triple combination not only did not deteriorate the quality of life of the patients, but the time to deterioration was much better when we use targeted therapy for BRAF mutant CRC metastatic patients, the same one with the FACT-C questionnaire applies. So we see that the results are much better when we use the Beacon regimen in patients that have BRAF mutant disease. But unfortunately, these patients recur in almost 5 months, and this amount of time is much less from what we are used to when we target BRAF, for example, in melanoma. And we know that the context of the disease is quite different in the colorectal cancer. This has to do a lot with EGFR overexpression, because when we inhibit BRAF in CRC patients, there is an upregulation in the EGFR pathway that renders at some time point these patients insensitive to the BRAF inhibition that we implement. But the results of the Beacon trial show that when we analyze these patients molecularly at the recurrence of the disease, these patients have a lot of mutations in different genes that remain at the MAP kinase pathway. And this is a characteristic case of a male patient that was treated within the Beacon trial, and his samples were analyzed upon progression, and you see that there have been developed several mutations in different mutations in KRAS, in HER2, in NRAS, in other genes that are implicated in the MAP kinase pathway signaling. And what does it signify? Is that, of course, the resistance is polyclonal, so a little bit difficult to treat, but also that the MAP kinase, the BRAF-mediated pathway, is still active in this population. And this, of course, has generated the hypothesis that we could still implement treatment targeting the MAP kinase pathway, and there are now phase 2 trials that are running mainly in Japan, trying to see if triple therapy immediately post or after one line of chemotherapy in patients that have recurred after encorafenib cetuximab treatment may be active in this population. And I believe that because we have some signal from the Beacon trial, this triplet therapy may have a role even in these patients. So what does guidelines say that up to now? The proposal, first of all, is that we should examine, test all our patients for the presence of BRAF mutation, at least when these patients are metastatic. This is a prognostic biomarker, and this is a predictive biomarker in a population that therapeutic options are quite limited and the disease is rapidly progressing. For the specific population of BRAF mutant patients, chemotherapy plus minus anti-VEGF treatment is the first line of first option we have for these patients right now, and the targeted treatment with encorafenib cetuximab is the preferable second-line therapy, and we should try not to miss the chance to treat these patients with targeted therapy. That is the most active treatment we have for the population of BRAF mutant patients. If we have, of course, dMMR, MSI high patients, immunotherapy is the initial approach for these patients, but again, we should take care to implement targeted therapy for all MSI high patients, as we'll see, that recur after immunotherapy in metastatic setting. And I'm showing you the whole algorithm from the ESMO guidelines, just to emphasize that when we start treatment in a metastatic patient with colorectal cancer, we have to be sure for the molecular profile. There are different options based on the different molecular profiles we have. There are different options based on the clinical status of the patients we have in front of us. For sure, the BRAF mutant patients should receive intensive chemotherapy plus minus anti-VEGF treatment up to now. And in second, and in case the patient has received another second-line treatment, in third-line treatment, encorafenib and cetuximab is the treatment of choice for these patients. And I emphasize for the first-line treatment because if we see the results we have up to now, the Beacon trial, even in the second or third line, because it also includes third-line patients, was quite effective with responses up to 22% in pre-treated patients. But the responses we have historically with chemotherapy in first-line setting is not much better, around 35%. And you saw the median PFS in the first-line setting is less than 6 months. And there is a phase 2 study combining the Beacon regimen with binimetinib that show much higher responses. So perhaps in the first line, targeting specifically the MAP kinase pathway BRAF could be much better than the standard chemotherapy we use up to now. And this is included in the phase 3 trial that attempts to examine if the addition of encorafenib cetuximab to chemotherapy, or even more encorafenib cetuximab alone, could be better than standard first-line chemotherapy in BRAF mutant patients. And in this clinical trial, there was a safety lead-in examining if the combination is feasible. And from these few patients that were included in the lead-in study, these patients were pretreated with chemotherapy, though, we see that the regimen was well tolerated. There were no significant DLTs apart from one case from neutropenia that was due to the chemotherapy administered to the patients. But you see that the responses are much higher, around 70%, independent of the chemotherapy backbone used. Most of the patients had some response, even these that could not reach the PR criteria according to RECIST criteria. And there were almost no progression in the first analysis of these patients. So this is very encouraging that we are going to have positive results by specifically targeting BRAF mutation in the first line. In these patients, you see that the median PFS in this small population is much higher than what we have seen historically up to now in the standard of care regimens in metastatic CRC in BRAF mutant patients. So I believe that the brief of conclusion of the authors that this is a very promising regimen to treat these patients is indeed true, and we expect positive results from this phase 3 trial that is currently ongoing. And before I close the presentation, allow me to share with you my clinical experience with a couple of metastatic CRC patients who we handled in the clinic. Of course, it's it's the good cases always that are presented as a part of a symposium, but these also have to give us two significant conclusions for how we should treat this patient. The first one was a 67-year-old woman. He was diagnosed de novo with metastatic adenocarcinoma of the transverse colon. He had peritoneal and liver metastasis, so very alike the population of patients with a BRAF mutation. And indeed, when we did her molecular profile, she was always wild type. He had the V600E mutation in the BRAF gene, and he was without microsatellite instability. The patient was diagnosed around May 2023, and on June 2023, he started first-line chemotherapy with CAPOX. We were afraid to start also anti-VEGF treatment because she was presented with symptoms of partial obstruction, so we didn't want to have any adverse events due to the administration of bevacizumab. And indeed, this patient, despite her biochemical markers were improving with the first-line treatment, 3 months later, he had clinical deterioration. He had lost a lot of weight. He could not eat a lot. He was presented with ileus, and the abdominal CT showed that there was a further increase in the abdominal mass, and that time there was an obstruction in the transverse colon. So this patient had no other option at the time. She went to have a palliative colostomy, and he was relieved by the symptoms of obstruction, but of course the disease was progressing rapidly. And a few days later, we started treatment with encorafenib cetuximab. The patient had a very good response. He was in PR and remained CPR 6 months later, and we hope that he could continue her treatment with Beacon regimen for some time still. So this is a good case that the targeted therapy improved significantly, not only for the matter of survival, but also for the quality of life and the symptoms of the patients. And we should also be aware that these patients progress very rapidly. So we have seen that the patient had biochemical improvement and the CEA marker was improving, but this doesn't say the whole story for a BRAF mutant patient. The second one was a 56-year-old woman. He was diagnosed due to anemia in our clinic, and we seen from the colonoscopy that she had a colonic adenocarcinoma of the cecum. She received a right hemicolectomy on June 2022, and the histology was a locally advanced disease. No lymph nodes that were excised were found to be infiltrated by the disease. Her molecular profile showed that she was again BRAF mutant, V600E mutation, always wild type, MSS, and approximately 1 month and a half later, she started on adjuvant chemotherapy with CAPOX, and the patients went very well with the treatment, but sometime around 5 months later, we see that the CEA marker was increased, and we performed an abdominal CT, and on abdominal CT there was now peritoneal disease. So we have a rapid progression in a patient that received adjuvant chemotherapy for her localized colorectal carcinoma. And despite, we may say that this patient should receive frontline chemotherapy, the truth is that this patient progressed while receiving chemotherapy. So we decided and started on the encorafenib cetuximab regimen. The patient had very soon partial response. Her CT exams were improving, and up to January 2024, the patient received this regimen. So almost 1 year receiving targeted therapy for a BRAF mutant patient. This is a significant amount of time, and we should take this into consideration when we're deciding which is the best appropriate treatment, because these cases show that targeted therapy administered even earlier in the course of the disease may have greater benefit for this type of patients. Of course, at some time the patient recurred. On January 2024, patient had liver metastasis, so she started treatment with FOLFIRI and bevacizumab. There was a stable disease. There is no response with the treatment. Of course, this is a quite difficult case furthermore. And I will close with the combination of biomarkers. You know that up 30% of patients with microsatellite instability, 30% of patients who have BRAF mutation are also macrosatellite unstable. And in colorectal cancer, you may remember this exceptional paper in New England Journal from Lee showing that these patients will respond up to 60% in pembrolizumab, and we have seen that in clinical practice, these responses will be deep and will last for a big period of time, a long period of time. And indeed, in the first-line Keynote 177 study, we see that the benefit of the addition of, the benefit of immunotherapy with pembrolizumab was similar between non-BRAF mutant and BRAF mutant patients. And again, we know that encorafenib cetuximab has the same benefit for patients that are MSS or MSI. So there is a rationale to use encorafenib cetuximab in MSI-high BRAF V600 patients, but you should take under consideration that these patients do not show well in the end in immunotherapy. And the reason for this is that macrosatellite instability is the second event in the pathogenesis of disease. These patients are driven more driven more from the BRAF mutations. And if we see the survival in BRAF mutant patients, these do not differ so much if the patient is MSI high or is MSS. And I believe that it's very important that studies like CMARC will study the combination of immunotherapy with this targeted therapy for this difficult population of MSI high patients. And with this, I would like to conclude my talk saying that BRAF mutant CRC patients is a difficult population. We see these patients in our everyday clinic. We should promptly check the molecules, test the molecular profile of the CRC patients so as to recognize these 10% that will have an adverse prognosis, and we should monitor these patients very closely and be eager to change our treatment towards targeting the BRAF mutation that seems to be the most beneficiary treatment for these patients. Thank you very much.